All right, everyone, it is 12 o'clock on the dot, so let's go ahead and get started. Good afternoon, everyone, and welcome to our Department of Medicine Grand Rounds. My name is Ryan Abe, and I'm one of the Medicine Chief Residents. I have the pleasure today of introducing our Grand Round speaker, Dr. Gail Jarvik. Dr. Jarvik is an internist and medical geneticist who holds the Arno G. Matulski Endowed Chair in Medicine and heads the Division of Medical Genetics here at UW-MC. Clinically, she cares for adult medical genetics patients. Her research focuses on the statistical genetic analysis of common diseases, including cancer, vascular disease, and dementia. She has broad research interest in the implementation of genomic medicine, including the work she'll present today. Her research in biomedical ethics includes returning genomic research results to participants. And she's also the 2021 past president of the American Society of Human Genetics. She'll be speaking with us today about precision medicine advances at UW Medicine and beyond. So without further ado, I'll turn over the stage to Dr. Jarvik. And as a reminder for those in the audience, please post your questions in the chat and I will pose them to Dr. Jarvik at the end of the presentation. So thank you and looking forward to the presentation.
Thank you very much, Ryan, and thank you everybody for joining us today. I have no disclosures. So I'm just going to tell you a little bit about the division before I tell you about science. The division was founded in 1957, or some say 1956. This image was taken in 1962, and the division founder, Arno Matulski, is here. This is actually a patient, and this is everyone interviewing the patient. And then this is a more recent picture of the division. We look forward to a day when we can all gather again and get a picture. We have 26 faculty, the minority of which are clinicians, and most of them are PhD translational researchers in genetics. However, we do have one of the largest adult genetics clinics in the country. The UW Medical Center site sees over 2,500 medical genetics patients a year, largely cancer and cardiac. Additionally, our faculty see a large number of patients, cancer patients at Seattle Cancer Care Alliance. We have had a residency or fellowship program for physician training for over 50 years. You can be board certified in medical genetics. You can also get a medical genetics consult. We have a brand new this year genetic counseling graduate program with 14 students enrolled. So we tend to be very involved at UW in large national programs. And so this slide's a couple years old, but this shows some of the programs that the NIH, in particular, the NHGRI or the Genome Institute have. And the ones with W's by them are ones where UW has a site. So you can see that we're really involved in the majority of these large genomic medicine programs. I'm going to talk to you today about two of them here, Undiagnosed Disease and Emerge, and I'll probably mention all of us along the way. So the Undiagnosed Disease Network, I'm going to give a little bit of short shrift, but I want you to be aware of it because you can refer your patients to this program. Any patient can apply. We see the WWAMI region plus Oregon. I left a W off because Wyoming was actually assigned to another site, but those patients can ask to come to us. This program, importantly, is funded through 2023. So if you have, I'm going to tell you more about it, but if you have patients, please think about sending them sooner rather than later. I'm going to spend more time on Emerge, the Genomic Risk Assessment and Management Network. This is going to invite enrollment from UW patients only. At our site, this will be 2,400 adults and 100 children. And most of the adults for UW will come from the Brotman Beatty Institute Biorepository. For both of the programs, we're returning the results to the participants and they will go in the medical record and care changes might be indicated. So you may be hearing about patients who are enrolled in either of these programs, but the second one is much bigger. So the Undiagnosed Disease Network is, as I said, a national consortium, and the overall goal is to end the diagnostic odyssey for complex undiagnosed patients. And in the process of doing this, we do discovery science. So there's a variety of clinical sites for this program. There's also proteomics and animal modeling sites, as well as a coordinating center. As I said, we're assigned this region, but we will steal Wyoming patients, and any patient in the country can actually request to come to us, but it tends to be done regionally. The inclusion criteria: the patient must be 1 month or older, have a condition which remains undiagnosed despite a thorough evaluation, have at least one objective finding. So we get into issues with patients whose primary complaints are pain, weakness, dizziness, things like that. We need one hard objective finding to enroll in the program. They have to be able to travel to us, although we do some remote and telemedicine work for this program. And they obviously have to agree to participate in research. They do not have to be English speaking to enroll in the program. Exclusion: not having that objective finding, being acutely ill and needing urgent care, someone who's just looking for long-term care. Unfortunately, cancer is not considered an undiagnosed disease for our program. If there is a suspected diagnosis with clinical testing that needs to be done, that person is not eligible, but sometimes we can help get that clinical testing done. And if they've had a really comprehensive workup where we don't think we're going to improve on that, that is also exclusion. So as I said, we go deep into the clinical evaluation. We gather the patient's medical records. They're reviewed by genetic counselors and physicians. We get all their labs, all their images. We also do DNA sequencing and RNA sequencing for the participants. Many more participants recently will come in with whole genomes, but that's less common for adults than children. And we're seeing about half children and half adults in this patient. We have this ability to do other studies, such as gene expression, metabolomics, functional studies, which is basically testing to see if a change in the gene affects its function in an assay, often in a test tube, but sometimes in an animal. And so these are things that you obviously won't get covered by insurance for patients, and so they really are in the research domain. And then we actually can also make model organisms to test if a specific variant affects the organism. So this is about a month old now, but nationally the program received about 5,400 applications. Some are still under review. A fraction of those are accepted. This is who's been evaluated so far. And out of these ones that are evaluated, we do pretty well at coming up with a diagnosis for people who have gone a long time without one. Largely, the diagnoses are made via sequencing. And when patients come in with a genome sequence, that drops our solve rate. The program has, across all the sites, found 39 new conditions. In other words, new genetic changes, a gene associated with a phenotype that was not known before. And they also have been involved in clinical and directed testing. So we spend a lot of time on the genome analysis. This is the analysis pipeline, and with credit to Liz Blue, who developed this pipeline. And she and Elizabeth Rosenthal do our analyses. I'm not going to go through this, just to say we really comb through the genetic data. It surprised me, I think, that these patients with an undiagnosed disease, when they get a diagnosis, there are a significant number that have a change in therapy. So 21% with a drug or other vitamin change, other changes in care, and a third. And of course, there is genetic and reproductive risk information associated with identifying the genetic basis for an unknown disease. So this is a case from, and this was, I would say, one of our easier ones. We saw this family. There's a proband who has a progressive neuromuscular disease, renal insufficiency, thrombocytopenia, epilepsy, and intellectual disability. And that person has a sibling with some, but not all of the same features. They had progressive disease. So the proband was in an electric wheelchair by 35. The sister at a younger age I'm hoping if you look at this family, you'll think to yourself, what is the most likely inheritance pattern? Maybe recessive. So what we did in this case is we did reanalysis of existing genetic data. So there was clinical genetic data, it was sequencing of all the coding regions of the genome. We reanalyzed this about a year after the original clinical test was done, and we focused on this gene. And in the affected proband and his sister, we saw this change, which was carried also by mom. And we also saw this same second change, which presumably comes from dad, but we don't have dad captured here. This was known to be a pathogenic or disease-causing variant for a neuromuscular disease. At the time, this was not, but this is now reclassified based in part on these data to be known pathogenic. So this was an autosomal recessive disease because of compound heterozygosity for pathogenic variants in the GNE gene. And that causes a condition that is known to cause foot drop, progressive muscle weakness. There are inclusion vacuoles on muscle biopsies. Those weren't noted in our patient's muscle biopsies, and thrombocytopenia is known to be associated with this condition. This did leave the proband's renal insufficiency, epilepsy, and then the shared ID, intellectual disability, from both the proband and his sister unexplained by this phenotype. And we see this commonly, that these patients are complex. They actually have more than one disorder. Sometimes we also can diagnose the second disorder, but sometimes we're just explaining part of the phenotype. If you get a patient with a list of 8 really impressive phenotypes, not always are they the same thing, right? All right, so this is where you can take a screenshot really quickly if you're interested in referring a patient to us. This is where you can get more information. It's very easy to find the Undiagnosed Disease Network website where patients can apply to be admitted. As I said, there's a significant screening process, and not all applicants will be admitted, but all applicants will be reviewed. And again, try and get in soon because the funding is going to go away. All right, I'm going to thank my team. So the top here, this is the faculty associated with this program. It takes a lot of experts and the staff as well. This is the lead clinical faculty. The day we took the picture, Mike's wife had a baby, so he got an excused absent from the group picture, but thanks to that team. And then the patient-facing individuals that will be interacting with your patient are shown here. All right, so moving on to the eMERGE network. So Genomic Risk Assessment Management Network, or JIRA. JIRA is this idea of we're going to put together monogenic information, so Mendelian things like BRCA1 pathogenic variants, polygenic conditions, which I'm going to explain in a minute in more detail, clinical factors from survey data, and then family history to get a informed risk assessment for the patient for risk of some common disease. This network is evaluating 20,000 adults and 5,000 pediatric participants. So again, the site map very heavily skewed toward the East Coast, as many of these consortia are, but here we are. We're the only clinical site on this side of the country. Invitae is lit up because they are providing lab services, which I'll mention. So we're happy to be representing the West here in this network. One of the goals of this program is to enhance the diversity in genomic studies, which is very problematic, and I'll tell you a little bit more about that. So we're focusing on underserved populations. The goal for each site is to recruit at least 75% underserved individuals. Here we are focusing on diverse ancestry, including Asian ancestry and sexual and gender minorities. And as I said, we are enrolling participants. We work with the Brotman-Beatty Institute to set up a biobank that would allow patients to also opt to enroll in this study. So if you had a patient who was in the Brotman-Beatty recent study led by Brian Schertz, they may be invited to join our study. I mentioned this problem we have in genomics of not having enough diverse data. One of the ways we're trying to overcome this is the All of Us network, which again, anyone, including you and your patients, can sign up to be a participant in All of Us. The goal of All of Us is to get over 1 million diverse individuals with deep electronic health record data, survey data, wearable data, as well as genomics. We are one of 3 genomics sequencing centers for this program, and we had our first genomics data release just a couple weeks ago of 165,000 individuals. And if you have data needs for trainees to do some basic analyses, they could look at these All of Us data, and it's a great data set. There's lots of things you can do with it, including things that are not genetics. So I mentioned this, genomic cohorts lacking diversity. This is sort of a timeline here, 1995 to 2020. This is the percent of non-European ancestry in a particular cohort. So you can see earlier, we had these big data sets that were predominantly European ancestry. Those continue to be generated, but in European countries mostly. In the US, we're more in this range. These up here, and I apologize to those of you who are red-green colorblind. I didn't make this figure, and so the coding is difficult, but the top here is participants who are wholly Asian from Asian countries. Unfortunately, these are very hard data to get your hands on. The MERGE program is right here on the figure, so we're doing better than many, although not as well as some. The All of Us research program is up here at about 50% European ancestry right now. The BioMe people in New York are the ones who made the slide, and they're doing a great job of getting diverse individuals into their biorepository. However, really for public data that people can analyze, All of Us is an opportunity, Emerge is an opportunity. Million Veterans is behind a VA wall, so if you're within the VA system, that's an opportunity, but a lot of these data sets are not ones that anyone can analyze. And that's one of the issues. One of the big ones anyone can analyze is the UK Biobank. However, that's very European centric. The result of that is if you look over time, the proportion of European individuals in genetic studies is sadly going up instead of down. And the reason for that is because we're using those UK Biobank data over and over and over again, because that's what's available and out there. And I will say credits to Malia Fullerton in our bioethics department, who has really put some attention and work on the lack of diversity in genomic data. All right, so what are we doing here for Emerge? As I said, we're going to target 2,400 adults in this age range, 100 children. We're not going below the age of 3 for the children. We're giving a gap between 16 and 18 because we have some issues when people become adults during the study. They have to be reconsented. We're trying to avoid that. This reflects the diversity in the Brotman-Beatty biorepository, which is where we're starting from. So it is 12% African. These are self-reported races here. 60% Asian, and historically, we've been in this consortium. This is our 4th cycle, so 14 years or more that we've been, and we have brought in most of the Asian data in the Emerge consortium. There's some Caucasian identified individuals. We also bring in most of the Native American ancestry individuals in the consortium, however, that still remains small. And then, of course, there are people who identify as multiracial. We didn't start initially asking about gender minorities, and we did over-recruit in this space. And so when we did start asking, it was about 23% gender minorities. It is about 61% female. That is who signs up after we send them an email. We're not targeting women. It may be, I mean, we see this in other studies, of course, but it may be particularly skewed toward women because it's the last study was informative for breast cancer, and this study will be as well. And of course, women or genetic females have more of an interest there. So we will start recruiting very soon, in just a couple weeks. And I did want to say that all of the lab reports from this will be CLIA lab reports, so they can be used for clinical medicine. And we don't expect those to start rolling until July. So this is the timeline for a participant. They'll be recruited, there'll be some screening. If they pass the screening, then they will be enrolled. We will get some more information from them. If they are in the Brotman-Beatty biorepository, we don't need that biospecimen because really all we need is DNA. If they are not, we will send a spit kit to their house so they don't have to come in to see us. MeTree is a genetic tool to collect family history. And then we will develop a polygenic risk score report. And then the monogenic, which again is the Mendelians like BRCA, I'll tell you more about that in a minute, will be generated. And then we're going to follow the individuals out after they get those results to see how the participants change their behavior, but also what medical tests their providers order. So that's the overall layout, and I'll drill down a little. One of our goals in this study is to minimize provider and clinic impact. So we're not asking physicians to recruit patients. We are not advertising in the clinic. We are enrolling from the biorepository or from extractions from electronic health data. We're not using clinic space or resources. We're not enrolling by telephone. The patients will be enrolled remotely. They're not going to be enrolled in person. As I said, we don't need them to come to us for DNA submission. And we will give them results and recommendations based on those results. Those will be shared in the electronic health record, and the provider and participant will be alerted. If they get a high risk polygenic risk score or positive Mendelian tests, such as BRCA 1 or 2, those results will be returned by a study genetic counselor with a clinical note. The patients are going to be filling out some surveys, and we're going to be paying attention to follow-up medical testing. So the Mendelian tests are really not part of the goal of the study. However, we felt like we couldn't give people a genetic risk for some of these conditions without also looking at the Mendelians. We didn't want to falsely reinsure someone who has a BRCA1 pathogenic variant by telling them they were low risk for breast cancer without looking at those genes. So we are looking at these breast cancer and ovarian cancer genes, the Lynch syndrome and some rarer colorectal cancer genes, familial hyperlipidemia genes, and then lamin A, which is associated with some cardiac conditions. We expect about 3% of the participants enrolled in the study will be positive for at least one of these things based on population and lab testing data. Children will not be tested for Mendelian conditions. If their parents enroll, the parents can be tested. Patients can opt out of the Mendelian testing as well, and it will be returned to the medical record. We are looking at polygenic risk scores for 10 conditions, going to review those in a minute. The threshold for high risk varies with the condition. That'll be reported on the lab tab. And again, that's a clear report that's coming from the Broad lab. The Invitae is generating the Mendelian testing. But then we're going to summarize in something called a JIRA, which I'm going to show you a little formatting for. All of these pieces of information, the Mendelian, the polygenic risk score, the family history. We're still figuring out where in the EHR that the JIRA is going to go. And we're working on clinical decision support problem list other places. And then to reassure you, positive results, the study will handle the return. I did want to just review quickly terminology for Mendelian or monogenic diseases. A positive test is not good news, as is true for most medical tests, but that's confusing to some of our patients and participants. That means there's a pathogenic or disease-associated variant. We prefer not to use the word mutation here. I know it's commonly used in media and even by some geneticists, but a mutation definitionally is a new change. So a de novo in a child whose parents didn't have that change. We really try and use the accepted terminology, I'll say, as pathogenic variant. Likely pathogenic is one that has significant supporting evidence, but is not conclusively pathogenic, and that we pick like a 90% level of certainty for that. It goes in the other direction of a benign variant that we're sure is not associated with disease. That's not the same as a polymorphism. A polymorphism is anything over 1% in a population, and it can cause disease. So sometimes you'll hear polymorphism used to mean benign, but that's incorrect. Likely benign on the other side, just like likely pathogenic, and then a big category in the middle of we don't know, or variants of uncertain significance. The vast majority of variants of uncertain significance will be benign when they're finally classified. However, as you look at them, there are things that you can tell about them that make you more concerned if they may be pathogenic or not. So sometimes you'll get uncertain significance, favor pathogenic. And then we will be returning autosomal recessive disease carrier status. That's considered a positive, but of course they're not at risk for disease if they only have one change. And then it's important that genetic classifications, especially the VUSs, will change over time. The goal is to get the VUS2 pathogenic or benign to understand, so that if people get VUSs, and even if they're in some of these other likely categories, there is updating of that information. Okay, so what exactly is a polygenic risk score? So when I first came to the UW, which was a long time ago now, I gave my first talk and my boss said, "That was great, Gail, no more equations." But I'm breaking that rule now. But I don't expect you to follow the equation. But the fundamental thing of a polygenic risk score is we're going to look at hundreds to literally millions of changes across the genome of common variants and that have incremental changes in risk. But if you summarize them all, you can get some real information. So unlike a Mendelian, where a single change gives you a higher risk, this is a group of information put together, and we're getting at, that complex part of the disease that is family risk that is not reflected by Mendelians. Polygenic risk scores, the core is this genetic information, but we are often layering in covariates like age and sex and family history and body mass, depending on your condition. So those covariates will vary between condition. Right, what are they good for? Well, when you do this, you get a normal distribution of risk. And so you can say that at the high end of the score is high risk, and you get to pick your percentile, what you want to call high. At the other end, of course, is low risk, and then there's kind of the middle in between. You can predict a variety of things with these scores. You can forecast a disease trajectory, which people are going to recover faster, for example. You can predict for obesity, which people are going to need interventions. There's actually really interesting data. I took this from a paper. These are all comers with coronary heart disease event rate here. If you put people on a statin, you lower the rate of disease by a few percent. But if you look at high risk individuals defined by polygenic risk scores, you have a much larger change in risk. So these are the people who you have the highest impact by being put on a statin. So you can identify them by their polygenic risk score. We are focused here on predicting disease risk. So here are the diseases we're interested in, or phenotypes. In the pediatrics group, we will be returning risk for asthma and risk for type 1 diabetes. For both the pediatric and the adults, type 2 diabetes and obesity or BMI. We stopped doing that at a higher age because it's not actionable anymore in older individuals. For adults only, so only for those of us who are over 18. In our study, most of these individuals will be over 25 because that's where our biorepository started. These are the conditions we're interested in. And I'm showing you the percent of people who will get a high risk score here, but I'll show you that again. So those are the conditions we care about. Really important to understand that the risk of disease depends on your ancestry group. Unfortunately for these polygenic risk scores, and that's something we're trying to improve. So that if you develop a polygenic risk score in a European population, such as the UK Biobank, and then you try and walk that prediction accuracy over to Americans who are of European ancestry, the prediction is not as good. South Asians, not as good. East Asians, even worse. African ancestry, significantly worse. So that you really have to develop these scores in multiple ancestry populations. And using multi-ancestry populations actually improves the prediction for every group. So we have a chart, which I don't expect you to memorize, of what the actual risk of disease is associated with our high end of our polygenic risk scores for our conditions of interest. So just walking you through asthma, you can see that it's approximately the same over ancestry group. It is not significant in Asian ancestry individuals, however, and it's, around 1.7. So these are risk factors. This is, comparable to like, do you smoke or not? This is not a highly, you're going to get this disease thing. For breast cancer, this is an example where, the odds ratio is about 2 or over for the other groups, but significantly less than 2 in African ancestry. So this isn't performing as well in that group. There still will be a top tail of percentage-wise, but those individuals are not as high risk. So all these data will be available so we can personalize the risk for our participants. And this just carries through all the disorders. I will say that for type 1 diabetes, the risk is quite high, but it's a very rare disease. So the prior probability is low. So even though you have a high odds ratio, the overall risk of getting the disease isn't high. And that is being returned to 1% of individuals. We're collecting only 100 pediatric patients at our institution. So on average, one of them will get a high risk there. There are some of these phenotypes that there aren't good data for Hispanic and Asian individuals. And there are ongoing analyses, including using the newly released All of Us diverse ancestry data to try and fill in those gaps. So overall, again, these are risk factors. This is not a screening test. This is not a diagnostic test. This is, you are at higher risk for something. Doesn't mean you're going to get it. And if you're at low risk, it doesn't mean you won't get it. Just a risk factor. Most of the odds ratios are in the 2 to 4 range. As I said, type 1 diabetes is higher but rare. There is often a similar risk as positive family history. So family history might be an odds ratio of 2. And then if you look, the PRS might be an odds ratio of 2. But interestingly, they're very independent. So if you put them both in the same model, they add information, which surprised me. So we're reporting things as high risk there. All right, so here are the conditions again. Importantly, this is the cutoff that we're using. Importantly, the breast cancer risk will not be returned to individuals who mark their sex at birth as male. So unless you say female, you won't get this back. Certainly males have breasts, but the model is not validated in males who have a much lower risk of breast cancer. More easily understood is why if you mark sex at birth female, you will not get a prostate cancer risk. Right, so this is what the information is going to look like. And there are going to be some trainings and some clinical decision support info buttons that can take you to a fuller explanation. But to make things easy, the cover sheet, while looking a little impressive, will just have a list of what is the highest risk for the participants. So this is an example where type 1 diabetes had high risk, so that it is high risk, and here are the healthcare recommendations associated with that risk. This is what the second page looks like, but let me blow up components for you. So this is what it would look like if the patient had a positive family history. Again, it will tell them a little bit about what that means. For type 2 diabetes, we're looking at other clinical factors, and those will be also summarized for the participant. The polygenic risk score itself will have a little chart, which will show what percent was high risk. I want you to notice that for whatever percent is marked high risk, 1 percentile under is not high risk. So if you're in the 97th percentile, you're being told you're not in that high risk group. Okay, so this is not a low risk group. This is, this part might be, but we are not distinguishing between if you're here or here. So it's important not to falsely reassure these participants that they're at low risk. There's a variety of electronic health record integration that goes in, and I'm not, just to say we're on this and, more to follow. There are care recommendations that will be returned with positive high risks. These have been developed by the consortia, and they vary from just a directed history and physical for some conditions to get a lipid profile for people who have a high risk of hypercholesterolemia. So those will be advised in a high risk report. And there also is, risk factors to assess, do they have other risk factors for the disorder, and then an education piece, of course, for each disorder. This is the overall study. So there'll be 25,000 participants. There'll be high risk group and a low risk group. And then we're going to follow what are the healthcare actions taken. And prediction is, of course, that there'll be more healthcare actions taken for the high risk than the low risk individuals. So we are looking at provider changes in testing that was recommended, as well as participant changes. The primary analyses are the number of new healthcare actions taken, and the secondary is newly diagnosed conditions. So that's a lower powered endpoint, but we're very interested to see if new diagnoses are made when people have these screening tests. The outcome types that we're following, this is just an example for one disorder. So did the clinician assess weight change or polyuria? Was there a hemoglobin A1C ordered? What is the physical, what is the BMI, etc. So those are the kind of things that we'll be following, and these will be followed in the electronic health record. So they should not take provider or participant time. We are concerned that some of the testing recommended will not be covered by insurance. The study has limited funds to cover some of these tests, but we need to know to order a research test before you order the test. So we can't have providers coming to us later and saying, oh, I ordered this hemoglobin A1C based on this high risk, and now the participant's insurance isn't paying for it. Most of these tests we do expect to be covered, but if you have any concerns, please reach out to the study. Things that come to mind are prostate-specific antigen for individuals who are 40 to 50 years old but have a high risk of prostate cancer, the diabetes autoantibody testing for people who don't have a positive family history. So what are the benefits to the participants? Well, improving our understanding of risk of prediction for common disease. You know, we've made a huge inroads in genetics for Mendelian disorders, but the things that kill people are cancer, heart disease, obesity, diabetes, and we need to be better able to predict, prevent, and get early treatment for those sorts of conditions. For adults, they will get free Mendelian testing for what are considered the most important health conditions. And of course, the CLIA testing will also be, for the PRS, also might help them reduce their risk of disease. The points to remember, we're testing multi-ancestry polygenic risk scores for 10 conditions in diverse people. We are going to look at a PRS. We're going to do some Mendelian testing in adults. We're going to look at family history, and there's some survey risk. At UW, a small number of pediatric patients, plus their parents will be offered enrollment, and mostly general adults from our patient population. CLIA tests going into the electronic health record. PRS is a risk factor. It's not determinative. A positive test doesn't mean you're going to get it. A negative test doesn't mean you won't. It's just another risk factor. Think of it like smoking or being overweight. Surprisingly, family history does not correlate as well with polygenic risk score as a geneticist might expect. So these are some resources. This is another screenshot opportunity. We're easy to find here at UW. You can always reach Emerge through me. We are developing public resources, including facts and condition-specific videos that are short, mercifully short. We have another amazing team for Emerge. My co-PI is David Crosslin, who was here in informatics but recently moved to Tulane. A huge team of physicians supporting this project, a huge team of very talented staff, the patient-facing staff that participants may talk to and you may talk to, Brenda and Martha on the study coordinator end, and Amy and Priyanka as genetic counselors. So with that, I'm happy to stop and hope you have some questions. Thank you.
All right, Dr. Jarvik, thank you for an excellent talk. I will open the floor up now for a Q&A. So folks in the audience, please post your questions in the chat for our speaker. We have one here that came a little bit earlier when looking at the sort of Emerge data that you showed before. The question is, what do you do with multiracial data? And if are folks allowed to pick more than one race, and how does that get influence the results that you see?
Yeah, that's such a great question because, of course, in the United States, large numbers of people are a mixture of ancestry group. When we do the testing, we actually look at the ancestry genetically with a very deep depth. So how the participant identifies themselves helps us enroll appropriately, but we actually correct for the ancestry using a large, multi-dimensional space of ancestry so that we are absolutely adjusting for individuals of multiple ancestry groups. It is an issue, and I will say a huge amount of work, it continues to be done to standardize what is being returned across ancestry group, and that is still ongoing. But for an individual participant, if they're saying, well, the odds ratio for this ancestry is 2 and the odds ratio for this ancestry is 1.7, and they know that they're of mixed ancestry, they're going to have to kind of project in the middle, and we can help with that. But we are not returning like ancestry principal components as part of this because it's a CLIA FDA approved test. That's not part of the test. We can't change the test.
I see. Great. Another question that just came through says humans are notoriously bad for interpreting risk and acting accordingly. And so do you have any thoughts on how best to counsel patients, or any observations that you notice from patients with how they sort of go about incorporating this risk assessment into their daily lives, or how they think about this?
Yeah, I think that's a really astute observation. Risk is a very hard concept, and I've had patients who didn't want to take a 0.003% risk of something. Literally, I calculated it. And I've had plenty of patients who are comfortable with a 50% genetic risk. So people have different comfort levels and they have different intuitive understandings. And I think a challenge for this study and a challenge for our genetic counselors is going to be explaining this as a risk factor and what a twofold risk means. And we will probably translate that to absolute risk. For some of the conditions like heart disease, they are actually going to give up like 25% risk of heart disease. So an absolute risk, most of the conditions are odds ratios. And so that takes some translation. I'm concerned at both ends because I'll be honest, I didn't like the terminology high risk. I wanted elevated risk because that twofold is high for many of these things. But I was voted down on that terminology. So I don't want people to be concerned that high risk is determinative. And I'm also concerned about those 97 percentiles people who are not going to get a high risk report. They're just going to get a not high risk report. And they're not at low risk. So I think getting people to understand a negative report for this is kind of like normal population risk, and high risk is elevated.
Mm-hmm. Kind of related to that question, do you have any advice for those of us who aren't geneticists for how to sort of counsel patients in this risk assessment and sort of what that means and how to interpret that for those patient interactions?
Yeah, I mean, I think if you frame it as a risk factor, like obesity, that obesity is more likely to give you type 2 diabetes, but it's not definitely going to give you type 2 diabetes. And you can get type 2 diabetes even if you're not obese. I think if you translate it to something that you're familiar with and understand that, that's helpful. And stay away from like calling it a screening test.
Right. Another question that came through too is that's kind of along the same lines is for the eMERGE data, are you going to be looking at sort of like patient reassurance, patient satisfaction, anxiety, or distress as sort of follow-up downstream measures of how they are interpreting this assessment?
Yeah, so there are follow-up surveys with patient understanding. I think they do touch on patient distress. I'm going to be honest and say that David Beanstra in our group is our outcomes guy. And so I'm trying to get the genetics in place. So I can't answer that, but I do expect to be covered. It's been covered in the eMERGE prior generations of eMERGE. And I think we're adapting some of our same surveys.
Okay, absolutely. Right. Open for any other questions. You have about 15 minutes left, and if nothing else comes through, we can end a little bit early, but I wanted to give people in the audience the opportunity to ask any other questions about this talk.
Let me anticipate the "can I sign up" question. If you want to volunteer yourself, again, we're recruiting first through the Brotman-Beatty. You would have to get your care at UW. And if you contacted me, I could put you on our additional waiting list. So.
All right. Well, if there are no further questions, we can go ahead and end a little early and get to our Fridays. So, Dr. Jarvik, thank you so much for that excellent talk. So interesting and really, really important work. And have a great weekend, everybody. See you next week.
Bye. Thank you.
Bye.